We're going to continue our conversation with more basics to pharmacology for advanced practice nurses. In Chapter 4, we're going to go over pharmacokinetics, pharmacodynamics, and drug interactions. Now, this is not meant to be completely comprehensive, so please refer to your book for more details, but more to serve as a reminder of what we already know about pharmacokinetics and pharmacodynamics. So first, to define pharmacokinetics, this is the study of how drugs are moved through the body, the movement throughout the entire body. And there's 4 basic pharmacokinetic processes. These are absorption, distribution, metabolism, and lastly, excretion. Absorption is the drug's movement from the site of where we administer the drug into the blood. Distribution is the drug's movement from the blood to the interstitial space of tissue and from there into the cells. Metabolism, also can be referred to as the biotransformation, is the enzymatically mediated alteration of the drug structure. And lastly, excretion is the movement of drugs and the metabolites out of the body. So the combination of metabolism and excretion together is called elimination. So these 4 pharmacokinetic processes act together to determine the concentration of the drug and the sites of action. Now, there's some characteristics of commonly used routes of administration that we're just going to summarize. And you can do a more thorough search and exploration of this in your textbook. But the 4 major routes of administration that we know of are the oral or the PO route, intravenous IV, intramuscular IM, and the subcutaneous or sub-Q. And the pattern of drug absorption, or for instance, the rate and extent of absorption within these sites or routes of administration is unique. So consequently, the route by which a drug is administered is going to significantly affect both the onset, but also the intensity of the effects of the drug. Now, you can see there's more distinguishing characteristics of the 4 major routes if you look at the table. There are, in addition, topical, transdermal, inhaled. And in each of these routes, they have unique characteristics, and we're going to address those characteristics throughout our exploration this semester as we discuss specific drugs used for these sites. Now we're going to look at the term pharmacodynamics. This is the study of the biochemical and the physiologic effect of a particular drug on the body and the molecular mechanisms in which we're trying to produce these effects. The dose-response relationship is the relationship that describes the size of the administered dose and the intensity of the response that it's produced. It's very fundamental when we are thinking about how we are prescribing within a therapeutic range. Now, this dose-response relationship is going to determine the minimal amount of drug that's needed to elicit a specific response and the maximal response that the dose can actually elicit, and how much to increase the dose if we want to produce the desired increase in response. And there are some basic features of this dose-response relationship that you can see more specifically in the book in Figure 411. There's also the drug-receptor interaction, and the drugs produce their effects by interacting with other chemicals. There's receptors that are unique and special to the chemical sites in our body that most of these drugs will interact and want to produce the effect. And we can define the receptor as a functional macromolecule within a cell. And that is going to bind to the drug to produce its effect. And although there are more formal definitions of receptors and functional macromolecules, The term receptor is just generally reserved for your body's own receptors for hormones, neurotransmitters, and regulatory molecules. The other macromolecules in which the drugs bind, such as enzymes and ribosomes, these are simply used or are thought of as target molecules rather than true receptors. Now, binding of the drug to its receptor is usually reversible. So the receptors can be activated by interactions with other molecules. Under certain physiological conditions, endogenous compounds like neurotransmitters, hormones, or other regulatory molecules can actually bind to the receptors to produce a response. But when a drug is in the molecule that binds to the receptor, all that it can actually do is mimic or block the actions of the endogenous regulatory molecules. And so by doing so, the drug will either increase or, if it's programmed, to decrease the rate of physiological activity that was normally controlled by that receptor. Because drug action is limited to either being able to mimic or to block our body's own regulatory molecules, these drugs cannot give cells any new functions. So to sum that up, drugs cannot make the body do anything that is not already capable. So we have to understand the terminology an agonist and an antagonist and what is a partial agonist. So we already learned that drugs bind to receptors and they can do one of two things. They can either mimic the action of an endogenous regulator or they can block the action of the endogenous regulatory molecule. The drugs that mimic the body's own regulatory molecules, these are called agonists. But those that block the action of endogenous regulatory molecules, these are called antagonists. So if they mimic, they're agonists, and if they block, they're antagonists. So like agonists, partial agonists can also mimic. However, they produce responses that are just intermediate in intensity. Agonists are molecules that activate a receptor. Because neurotransmitters, hormones, and other endogenous regulators activate the receptor where they're binding, these compounds are called agonists. And when drugs act as agonists, they simply bind to the receptors and mimic the actions of your body's own regulatory molecules. Let me give you an example. If we give someone dobutamine, this is a drug that mimics the action of norepinephrine at the receptor on the heart. And so thereby giving dobutamine will cause the heart rate and force the contraction to increase. It's doing with what norepinephrine would do. So in terms of a modified occupancy theory, which is a theory that talks about an agonist being a drug that has both the affinity and the high intrinsic activity. Affinity allows the agonist to bind to the receptor, whereas intrinsic activity allows that bound agonist to activate or turn on that receptor function. Let's talk about antagonists. These produce their effects by preventing a receptor activation by endogenous regulatory molecules and drugs. Antagonists have virtually no effect of their own on the receptor function. So in terms of, again, we're talking about this modified occupancy theory, an antagonist is a drug with the affinity for the receptor but no intrinsic activity. Affinity allows the antagonist to bind to that receptor, but because there's a lack of intrinsic activity, it's going to prevent the bound antagonist from causing any activation within that receptor. Although antagonists don't cause receptor activation, they most certainly can produce a pharmacological effect. And this is how. Antagonists will produce their effect by preventing the activation of the receptor by the endogenous regulatory molecules. Let me give you an example with antihistamines. These are antihistamines are histamine receptor antagonists that suppress allergy symptoms by binding to the receptor for histamine. And when these antagonists or antihistamines bind to this receptor, they're going to prevent any activation of that receptor. So therefore, where histamine could be released in response to allergens, we are suppressing that activation. Now, it's important that we understand that antagonists will, the response is to determine how much agonist is actually present, because antagonists act by preventing receptor activation. So if there's no agonist present, if we administer an antagonist, there's not going to be any observable effect. The drug will bind to the receptor, but nothing is going to happen, or we are not going to see anything happen. And on the other hand, if receptors are undergoing activation by agonists, and then we administer an antagonist, this is going to shut down the process. So it's going to result in something that we can actually observe. The example of naloxone is a good example. We're going to use opioid antagonists, right? So Narcan, naloxone. This is used to block the opioid receptor in the event of an opioid overdose. Now, antagonists can be subdivided into two major classes: non-competitive antagonists and competitive antagonists. But most antagonists are competitive. When there is a non-competitive antagonist, they will bind irreversibly to receptors. The effect of an irreversible binding is equivalent to reducing the number of receptors available for activation for an agonist that could activate it. Because the intensity of the response to an agonist is going to be proportional to the number of receptors that are being occupied, and because non-competitive antagonists decrease the number of receptors available for action, these non-competitive antagonists actually will reduce the maximal response that an agonist can actually elicit, because there's something blocking it. If there are sufficient antagonists present, the agonist effect is going to be blocked completely. Lastly, we're going to get into partial agonists. So with partial agonists, this is an agonist that can only do things moderately. Okay, so as a result, the maximal effect that a partial agonist can produce is lower than that of a full agonist. Partial agonists are interesting because they can act as antagonists, but they can also act as agonists. And so for this reason, they're sometimes referred to as agonist antagonists. And sometimes we just call them partial agonists. They're synonymous. So let's think of an incident where we would give a drug, pentosazine. If we give this by itself, it's going to occupy an opioid receptor and produce a moderate relief of pain. But in this situation, the drug is actually acting as an agonist. However, if a patient's already taking, let's say, meperidine, which is a full agonist that works on the opioid receptor, and then if we give them a large dose of pentazocine, it's going to occupy that opioid receptor. Therefore, it's going to prevent the activation or the full activation of meperidine. So now can you see how it can also act as an antagonist? The patient is going to experience only the limited relief because it is actually blocking the receptors to take on the meperidine, which is going to do a better job because it's a full agonist to reduce pain. So therefore, pentosazine is giving partial pain relief, so it's acting as an agonist, but it's also blocking the receptors of meperidine, so now it's also acting as an antagonist all at the same time. So it's blocking the higher degree of relief that could have just been achieved if we only gave meperidine by itself, a full agonist. We're going to move on to adverse drug reactions and medication error. So in its simplicity, a side effect is defined as a nearly unavoidable secondary drug effect produced when we give a therapeutic dose. Now, common examples are like drowsiness, GI upset or irritation, Can you think of two medications that would cause those things? Traditionally, antihistamines cause some drowsiness. They're working on that histamine receptor. And aspirin can actually cause GI upset or GI irritation. So those are examples of side effects. And they're generally predictable. They've been well studied, and we know that the intensity is also dose dependent. Some side effects only develop if we are just starting a drug for the very first time. Some only develop at a certain dose. And then other side effects don't even appear unless we've taken it for a few weeks or a few months or, too long. The term toxicity, this formal definition of toxicity, is the degree of detrimental physiological effect that's caused by drug dosing, excessive drug dosing. And so think about respiratory depression that can happen if we prescribe too much morphine, or if there's an overdose of morphine, or if we give too much insulin, we are going to have a toxic reaction of severe hypoglycemia. So both side effects and toxic effects are bad, but one is common and predictable, and the other one is because we gave too much, and it has a higher degree of detriment to the patient. Now, this term toxicity, formal definition, includes only severe reactions when there is overdose or excessive dosage. But in everyday language, we tend to use the term toxicity to mean anything, severe, regardless of what dose caused it. So, for example, when we give a medication or prescribe a medication within the therapeutic range, many anti-cancer medications can cause neutropenia. So we understand this, we know this. But therefore, this is going to put the patient at high risk for infection. This neutropenia can actually be called a toxicity, even though we knew that it was going to happen with the dosage, and the dosage was meant to be therapeutic. Allergic reactions are a direct response from the immune system. And so for allergic reactions to occur, there has to be prior sensitization of that immune system. And after the system has been sensitized to a specific drug, it's that re-exposure that triggers the allergic response. The intensity of the allergic reaction can range from mild itching, and it could be a more severe rash, but also it can lead to anaphylaxis. 10% of adverse drug reactions, or ADRs, are really of the allergic type. The intensity of the allergic reaction is going to be determined primarily by how sensitive your immune system is to that drug, not necessarily just the drug dosage. So let's think about it in a different way. The intensity of allergic reactions is largely independent of the dose. So as a result, the dose doesn't really elicit the reaction in one patient over another. It's the sensitivity to that drug of that specific patient over a certain amount of time. For few medications that cause the allergic reactions, we still need to be in tune with the serious reactions that can happen. And it can happen by just one drug family, like the penicillins. Other drugs that can cause allergic reactions, we have some of the non-steroidal anti-inflammatory drugs like aspirin. Other drugs that are very common, like the sulfonamide, and they include diuretics, antibiotics, and oral hypoglycemic agents. So those are pretty common. And you're going to learn this semester even more the common drugs that will produce side effects, allergic reactions, and toxicities to our patients. So those three are pretty common terms that we probably all understand. Now we're going to get into a little bit more of the things that we may not know commonly. So idiosyncratic effect. The idiosyncratic effect is defined as an uncommon drug response that results in a genetic predisposition. So an example of an idiosyncratic effect is or can be explained through the process of G6PD deficiency that can happen in people when they have a glucose 6 phosphate dehydrogenase deficiency. So G6PD deficiency is an X-linked inherited condition, and it occurs primarily in people with African or Mediterranean ancestry. And when people with G6PD deficiency take some drugs, such as sulfonamides or aspirin, they're going to develop varying degrees of hemolysis of their red blood cells. And this can be life-threatening. Paradoxical effects, these are opposite effects that were intended for the drug response. So a common example is the excitement that may occur when some children take a first-gen antihistamine, like over-the-counter sleep aids. Instead of making them sleepy, paradoxically, they actually make them more excitable and more hyper. Similarly, when older adults experience a paradoxical excitement, it could be, when we give them a benzodiazepine for sedation, they actually become a little bit more awake and hyper. So some drugs can cause paradoxical effects on our patients. Iatrogenic disease is any disease that occurs as the result of medical care or treatment. So that term, iatrogenic disease, is when we have found a disease that was produced actually by the drugs that were prescribed. Okay, so not something that we want to see in the patient's chart. These type of iatrogenic diseases are nearly identical to natural occurring diseases. Like, for instance, if a patient takes a certain antipsychotic drug, they may develop symptoms that closely resemble Parkinson's disease, but it's because of the drug. And now we're going to define the last three: physical dependence, carcinogenic effect, and tetragenic effect. So physical dependence is when your body has adapted to the drug, the exposure, in a way that now if you remove this drug, they're going to go into abstinence syndrome. And it's usually when the drug is discontinued or even sometimes reduced to a lower dosage. Physical dependence develops during this long-term drug use. And typically these drug classes are like opioids, alcohol, barbiturates, and amphetamines can also cause physical dependence. So the precise nature of abstinence syndrome is really going to be determined by the drug that was involved. And although physical dependence is usually associated with opioids, these are not the only dependence-inducing drugs. We have other drugs that can promote dependence as well, like we talked about ethanol or alcohol, barbiturates, and amphetamines. Some drugs that work outside the central nervous system can also cause physical dependence as well. And because there's a variety of drugs that can cause physical dependence in one, shape, form, or another, withdrawal reactions have the potential for harm, and we need our patients to understand that if they abruptly discontinue these type of medications, they may have other resulting problems. Carcinogenic effects, this refers to the ability for a certain type of medication and environmental chemicals to cause cancer. Unfortunately, there are only a few therapeutic agents that are carcinogenic, but ironically, several of the drugs that are used to treat cancer are among those with the greatest carcinogenic potential. Luckily, there are not very many drugs that do this. So we have to evaluate the drugs very closely. It is very difficult, thing to do when our patients have cancer. And luckily, we have fantastic oncologists and pharmacists that specialize on with these type of medications that help us do this. Lastly is the tetragenic effects, and these are when drugs can actually induce birth defects. And so medications and other chemicals that are capable of causing birth defects, we term those tetragens. And you can further understand more about teratogenesis in chapter 8. Okay, so organ-specific toxicity. There are many drugs that are toxic to specific organs, such as the liver, the heart, the kidneys, and we talked a little bit about that already in the previous presentation. Common examples of drugs that injure the kidneys, if you think about the antifungal drug, amphotericin B, directly can injure the kidneys. Doxorubicin or rubicin, this is a drug that can cause heart disease, directly injures the heart. This is an anti-cancer drug. Amiodarone, which is a drug that we give to patients with dysrhythmias. This can injure the lungs. There are some actual antibiotics and also can cause lung scarring as well. Aminoglycosides, which is a class of antibiotics. Think of the mycins like gentamicin. These can injure the inner ear and cause ototoxicity. So these type of drugs need to be monitored, and you need to know so that you can understand as a provider, but also you need to tell your patient so that they can see if they're developing any of these type of symptoms. There are two types of organ-specific toxicities that we need to really pay close attention to. The first one is injury to the liver, and then those that alter the cardiac function. So think of drugs that prolong the QT interval on your EKG. Okay, but first we're going to talk about the hepatotoxic drugs. These drugs, hepatotoxic, means they're going to be metabolized by the liver and they're converted to toxic products that then actually injure the liver as it's being metabolized. So hepatotoxic. So in the US, there are drugs that cause acute liver failure. They are actually the leading cause of acute liver failure because they are being metabolized and directly affecting the liver, and they can be fatal. But fortunately, liver failure from hepatotoxicity is rare. It only happens in about 1 in 50,000, but knowing can actually reduce your patient's risk to be that 1 in 50,000. Drugs that cause liver failure more often are removed from the market before this has the potential to hurt anyone. But again, everybody's body metabolizes or reacts to the metabolism differently, and it just depends on your baseline health of that organ. More than 50 drugs are known to be hepatotoxic, and you can see them listed in your book. The last thing we're going to talk about on this slide is QT interval drugs. And the term QT interval means simply these medications that prolong that interval between the Q and the T on an EKG. And this causes a risk for severe and very serious dysrhythmias. The QT interval is measured from the time required from the ventricles to repolarize after each contraction. And when that interval is prolonged, or more than 470 microseconds, in post-pubertal males and 480 microseconds for females, they can develop dysrhythmias, and these are known as torsades de pointes, which can progress to potentially fatal ventricular fibrillation, VFib. There are more than actually 100 drugs that can cause QT prolongation or torsades de pointes or both, and you can see that also in your textbook in the chart. And so these QT drugs are found in many drug families. And some of them have been withdrawn from the market because they've been increased deaths linked to their use. And then other drugs have been restricted in the US, and the US Food and Drug Administration, or the FDA, actually requires that all drugs be tested for QT prolongation before it gets put to market. Okay. It can sometimes be very difficult to determine whether a specific drug is responsible for the observable reaction because other factors are involved, like underlying illness, if there's other drugs that have been taken, have they taken it correctly? So it's really hard sometimes to know if the drug that you prescribed was the actual cause of whatever reaction the patient is happening. So to help determine what particular drug is responsible, we have to ask ourselves some questions and consider, does the patient have underlying illness? Okay, and did the symptoms appear shortly after the drug was first used? Did the symptoms abate when we discontinued the drugs, or did the symptoms go away? Did the symptoms reappear when we reinstituted the drug? And ask yourself, is the illness itself sufficient to explain the event? And were there other drugs in the regimen that could have explained the event as well? So, think about all the situation holistically, and if your answers reveal that there was a temporal relationship between the presence of the drug that was prescribed and the adverse effect, and if the event cannot be explained by anything else, then there's a high probability that that drug is the culprit, that you're suspicious about, and then we need to look into stopping the drug immediately or finding another regimen. Now, this process is very limited. It doesn't, confirm 100% of the time that that drug, if it fits this description, is the one that's causing an adverse drug reaction. But it is a start. And, we can't always identify the effects that are going to develop slowly over prolonged drug use, but the immediate effects we definitely can reduce. Okay. So ways to minimize our adverse drug reactions: first, be responsible by understanding the drug itself. We need to know that the pharmaceutical industry is doing its best to provide safe medications in a manner to where it can get to the public, but also that it's reducing harm. And then also we have to understand that using drugs that are toxic to specific organs or that function the target organ, that we need to monitor it closely. So basically, this is our responsibility as providers. Know that we do our best to follow FDA regulations. We have FDA approved medication guides that we are supposed to follow. We want to look for the boxed warnings, so what they have already understood could be possible complications, and make sure that we are also looking at the risk evaluation and mitigation strategies to reduce adverse drug reactions. So in order to reduce medication errors collectively, we need to help and encourage patients and their families to be active and informed members of the healthcare team, to think about them as members of the healthcare team. Remember, we're taking a patient-centered approach. We want to give providers the tools and information they need to prescribe, dispense, and administer drugs as safely as possible. And we want to prescribe within the guidelines that are set up for us to be safeguards. We want to institute appropriate safety checks for high alert drugs. We have actively been trying to replace handwritten medication orders with computerized and standardized orders so that there's no miscommunication or error there. We want to have pharmacists accompany physicians when we do hospital rounds so that they are there to be that sounding board and a person of expertise. As providers are trying to come up with regimens, they can, right then and there tell us, will this work or not? Now, we don't have that in clinical situations, but we can always, if we are in doubt, call the pharmacy in which we are prescribing to ask the questions. We want to reduce errors by not using error-prone abbreviations. We know this from our education as registered nurses as well. And we want to perform medication reconciliation always to understand, what are the medications that the patient has been prescribed, that they're actively using, that they have at home, and that they have access to. Because sometimes, even though they may say they're not taking it now, and we say, okay, well, then if you're not taking drug X, then I can prescribe you drug Z. But then later on, we know that we find out that they are actually taking drug X because they decided, well, I'm having these symptoms, so I'm going to take that again. And therefore, they take drug Z and drug X at the same time. And we knew that X and Z didn't mix, but they didn't know. So we really want to do a good job at performing this medication reconciliation and dispense any more information that we can give them to provide further clarity and make sure that they really understand how to use their medications appropriately. Now we're going to talk about individual variations in drug responses. So really brief 3 slides talking about the variation in drug responses. The components are body weight and composition. So the intensity of some of the drugs and the response to the drug is determined by the concentration of the drug at the site of action. So the higher the concentration, the more intense the response is going to be. Therefore, body size can be a significant determinant of how the drug is actually going to affect the body. We might have to adjust the dosage based on body surface area, because the surface area is going to determine how the body's ability to absorb, or the adiposity to that drug. Because the percentage of body fat can change drug distribution and alter this distribution, it can change the concentration of the drug at the site of action, therefore changing how much will actually get into the blood, and therefore where it's meant to go and be targeted. Age also is a component that we need to consider. Drug sensitivity can vary with age. Infants and older adults are especially sensitive to drugs, and even very young patients. And so therefore there are other dosages available for certain drugs, like let's say for Tylenol, for instance, or acetaminophen. There's an infant dose, there's a pediatric dose, and there's an older adult dose. And then, of course, you think about how it's going to vary if they have an underlying organ disease, right? So liver disease or kidney disease, for instance. The clinical challenge is really created and heightened due to drug sensitivity in very young and very older patients. So really do a good job and be comprehensive at all times, but even more so with these populations, finding the correct dose that is going to work for them. We need to understand the pathophysiology. So again, knowing where the drug is going to interact. Kidney disease, liver disease, if there's any acid-base imbalance or electrolyte status that our patient has. How it is being tolerated within the body. So thinking again in terms of pharmacodynamics, the metabolic tolerance, and the tachyphylaxis. So that is maybe a term most people aren't familiar with. This is a reduction in drug response brought on by repeated dosing over a short time. So think about It's different than pharmacodynamic tolerance and metabolic tolerance, which take days or longer to develop. Transdermal nitro, for instance, this is a good example of tachyphylaxis. When we give nitroglycerin through a transdermal patch, effects are going to be lost in about 24 hours if the patch is left in the same place all throughout the day. So that loss of effect is going to result in the depletion of the cofactors that are required for nitroglycerin to actually act. And so when we give this nitro on an intermediate schedule, rather than just continuous leave it, don't change it, the cofactors can be replenished between doses, and then there won't be any loss of effect because we have been moving it around. Okay, so think of nitro patches when you think of tachyphylaxis. And then lastly, the placebo effect. This is devoid of any intrinsic pharmacologic activity. Therefore, any response that the patient may tell you is a placebo based solely on the patient's psychological reaction to the idea of taking a medication, but it's not really having any physiologic or biochemical action of the placebo itself. The primary use of placebos, if you can think about that, is really during clinical trials. And so in pharmacology, the placebo effect is defined as the component of a drug response that is caused by psychological factors and not by biochemical or physiological properties of the drug. Last for this section is the variability in absorption. Both the rate and the extent of drug absorption can vary among our patients, and with that, the timing intensity of the response can be changed. The bioavailability. This is a term that we use that refers to the amount of active drug that reaches the systemic circulation from where we administer the drug or the site of administration. Now, different formulations of the same drug can vary in bioavailability. So think about factors such as a tablet disintegration time, things that have enteric coatings around it, or sustained release formulations. These can alter the bioavailability, and that's going to make the drug response variable. Differences in bioavailability occur primarily with oral PrEP rather than parenteral PrEPs. Fortunately, even with oral agents, when there are differences in bioavailability that exist between preparations, these differences are pretty small and they don't have, very much clinical significance. The bioavailability differences that are more concerning are those that have a very narrow therapeutic range, because these drugs have a relatively small level where they can change that is going to produce a significant or insignificant response in the patient. So a small decline in a drug level may cause therapeutic failure, or a small increase can actually cause toxicity. So under these conditions, knowing the difference of bioavailability could have a very significant effect on the outcome. So what are the individual causes of variable absorption? Individual variations affect the speed and the degree of drug absorption that affect the bioavailability and can thereby lead to various drug responses. And so think about your gastric pH. This can affect your absorption through the pH partitioning effect. And for drugs that undergo absorption in the intestines, absorption will be delayed when gastric emptying time is prolonged. So diarrhea can reduce absorption because it's accelerating the transport of drugs through the intestines. Conversely, if you're constipated, this is going to enhance absorption because the drugs are, they have a prolonged time that they're available for absorption. Other things that can play a role in this is genetics and pharmacogenetics. Each person has a unique genetic makeup that can lead to drug responses that are qualitatively and quantitatively different than the total population at large. And adverse effects and therapeutic effects can be increased or reduced. There are also gender and race related differences in some drugs, ultimately genetically based. However, general discussion is warranted. Men and women respond to a drug differently. Some drugs are more effective in men than women, and vice versa. And other drugs, they can be more intense in men than in women, or vice versa. So, unfortunately, most drugs, we don't have adequate knowledge about gender related differences if they were approved before 1997. At this point, the FDA pressured drug companies to include women in their trials of new drugs, where before they were not. And so most of these drugs were only tested on males. Now, essentially, all drug research was done in men before this time, but now, more of the newer medications, we have a clear understanding of how it may affect genetically. Let me give you some examples. When we have a patient with heart failure and we give digoxin, this can actually increase the mortality in women. But it could essentially have no effect on the mortality of men. We also know that alcohol is metabolized more slowly in women than in men, and that's why we have different ranges of what the recommended daily intake of alcohol should be. And as a result, a woman who drinks the same amount as a man, on a weight adjusted basis, they're going to become more intoxicated. There are certain opioid drugs that are more effective in women than in men, and so therefore pain relief is achieved at lower doses if we give it to a woman than we give it to a man. There are some medications that are going to cause greater QT interval prolongation in women than they would in men. And so therefore, if we think about quinidine, for example, if we give this to a woman, they're more likely to develop torsades de pointes, which we talked about already, is fatal cardiac dysrhythmia, more likely than a man would. So although there's still a lack of adequate data related to the drug effects of women and men, we have more information now for the different genders because the FDA is essentially requiring them to do this. So, in the meantime, clinicians have to be able to stay informed, know what the current research is, and the information that is up to date, so that we can avoid treatment failures or unexpected adverse drug side effects. In terms of race, there are certain drugs that don't work as effectively on certain races. So there is a drug that is a combination of two vasodilators out there. And in 2005, this became the first drug product that was approved by the FDA for one single racial group. And it was approved for African Americans that had heart failure. And it demonstrated that African Americans that took this drug, it was more effective. And we already know this in some of our antihypertensive medications, that there are some racial populations that will not metabolize the drug the same way, and therefore it's not the best medication to give this genetic, people with this genetic makeup. So we need to find them a better medication. Also with comorbidities and drug interactions. Now, individuals often have two or more medical conditions or disease processes in general. As they get older, typically that number will increase. But when when reactions occur, drugs have to, we've got to think about how we're going to manage a patient that's complicated with multiple drugs on hand and there's multiple comorbidities. For example, if a person has asthma and hypertension, we have to think about using a non-selective beta adrenergic antagonist or a beta blocker to control blood pressure. But when we do this to control blood pressure, it may worsen the asthma symptoms because that dose is sufficient to cause airway constriction. You think about what the drug is doing to all systems. Because patients with comorbidities often take multiple medications, there is an increased likelihood of drug interactions. We know this. We have to just remember to make sure as providers now, pharmacology from a provider's perspective, that we're keeping that in the forefront of our critical thinking. Lastly, we are going to talk about genetic and genomic considerations in pharmacotherapeutics in a little bit more detail, but just bear with me for 4 more slides. So with pharmacogenomics, the National Institutes of Health define this term as the study of how genes affect our response to drugs. And the purpose of pharmacogenomics is to combine the science of genomics and pharmacology so that we can provide more individualized, targeted, safe drug therapies to patients. So think about patients that have a particular type of cancer. We want to not only treat that cancer, but how do we treat that cancer best with the genetic makeup of that person? So some may include pharmacogenomics within the practice of personalized medicine, or what we call precision medicine. But truly, pharmacogenomics falls under the category of precision medication, right? Because we're trying to target a specific genome. Although the two terms are often used interchangeably, when we talk about precision medication, this is really referring more to the general approach to finding effective strategies for treating similar groups of patients with specific genetics, lifestyle, or environmental factors, etc. This precision medication was developed by the idea of personalizing medication regimens. And the reason personalized medication has fallen out of favor in healthcare is that, while we are trying to treat patients on an individual basis, scientists are not developing novel treatments, new things that will consider the individuality of patients. So this is a young science, and it's producing significant clinical information that's relevant to healthcare right now, but it's still in a very young stage. And a patient's unique genetic makeup can lead to drug responses that are qualitatively and quantitatively different from those of the population at large, and that's what we want. Same thing with adverse effects, and therapeutic effects. We want to safely prescribe while reducing any type of adverse or unexpected reaction. And so, using information like biomarkers and the genetic profile of the patient, we're hoping to find better, targeted, more personalized approach to treating our patients. So just something worth thinking about or researching. I think it's a great springboard for a DMP project as well. And then thinking about genetic variants that will alter the target drugs. So genetic variants or variation can alter the structure of how the drug receptors are and the other target molecules that can influence the response. And these variants have been documented in normal cells and in cancer cells and also in viruses. And so these genetic variants that affect the drug targets on normal cells, you can see them here. There are variants in the genes that code for the beta-1 adrenergic receptor. This produces receptors that are hyporesponsive to activation. This can be a good thing and a bad thing. The bad thing is that with people with hypertension, activation of these receptors are going to produce an exaggerated increase in blood pressure. The good news is that people with hypertension, the blockade of these receptors will therefore produce an exaggerated decrease in blood pressure. So, it's a mixed bag. Good and bad can happen. You think about the anticoagulant warfarin, right? So it works on inhibiting vitamin K, epoxide reductase complex 1, VKORC1. But this variant gene that codes for VKORC1 is produced to form the enzyme that can be easily inhibited, and hence anticoagulation can be achieved with very, very low warfarin doses. So if normal doses are given, anticoagulation will be excessive and then bleeding could result. So to reduce this risk, the FDA recommends testing for variants in this gene before warfarin is used. And that is just, some examples of how drug targets on a normal cell. Now, what about on cancer cells in viruses? So there's a drug, Herceptin, used for breast cancer. And it only works against tumors that have an overexpression of the HER2. And so this HER2 protein serves as a receptor for hormones that stimulate tumor growth. And it's overexpressed in about 25% of the breast cancer patients. Now, this overexpression of HER2 is associated with poor prognosis, but also can predict that they're going to have a better response to Herceptin. So the FDA requires a positive test result for HER2 before they can actually use Herceptin as a therapy for that type of cancer. So you can look for, there's other genetic variants and other responses, but that's the gist of genetic variants that alter drugs and their drug targets. Okay, we're winding down. Last couple of slides, genetic and pharmacogenetic testing. We have genetic biomarkers like blood, saliva, urine, amniotic fluid, tissue, and hair, and genetic testing. And so to perform complete testing, providers have to have access to facilities that can actually do these things, or facilities that they can refer out to do these things, right? So lab analysis of genetic biomarkers. But due to the explosion of research and technology, there are more than 70,000 genetic testing products on the market out there. 10 products enter the market every single day. But knowing which ones to use and why are going to be key. The ability for the public, for our patients, to access genetic testing is increasing. In 2018, the FDA approved direct-to-consumer testing for breast cancer risks. This test kit was provided by the company 23andMe. You probably have heard about that company. They can, tell you about your ancestry. But they are also creating genetic testing for medical research. We have tests for the BRCA1, BRCA2 gene mutations. This can be done through saliva. We have these tests, and although it's just helping us right now, it's just increasing the availability of genetic testing. Not all patients have access yet. And the FDA actually cautions patients and providers about using the tests because they don't want it to be looked at as a definitive guide for treatment. Okay, it's still just a screening test. Think about knowing if you have BRCA1 or BRCA2 doesn't necessarily mean that you would be diagnosed with breast cancer in the future. And so patients may, act more drastically thinking that they are that they are going to get breast cancer, but they may not. The BRCA1 and BRCA2 genes have more than 1,000 mutations, and the test only diagnoses 3 of these mutations. So it's not a definitive guide. Like if you're positive, you still may not get breast cancer, but if you are negative, it still may not mean that you might not get breast cancer or you don't have the predisposition because of these genes. Okay, so they're not definitive. There are other biomarker tests and genetic test kits out there to be aware of, but this is still a new science as well that we're learning about every day. For those of you that are really interested in pharmacogenetics or have patients that would like to participate in, tests and screeners that will look at their treatment from a pharmacogenetic standpoint, we can only help them interpret the test and give them the information that we need or that they need, but we also have to educate ourselves in order to make this a valuable part of the treatment plan. But the barriers that you might see are the lack of education of your patients. They may not understand all the information or understand what this genetic testing may mean, but also the financial cost for testing. So most insurance plans aren't covering genetic testing right now as a preventative option. But as we promote precision therapy and precision medication becomes more prominent, more insurance companies are going to more likely begin to start paying for some of these things because, if they can prevent disease, it reduces cost over time. But right now, it is very expensive, and sometimes these genetic tests, they can vary from $100 or can go up to $2,000 or more dollars per test. So it really depends on what the test is or the test panel. I do have a handful of patients that are waiting for genetic testing that can't get it unless they meet XYZ criteria, which they're having a hard time doing. So therefore they don't qualify for it to be covered, and they have to pay out of pocket. All right, so that is the end of our presentations for this week. We'll see you at the next presentation.